I'm Danielle Hessler-Jones, one of the co-directors of SIREN, and it is my pleasure to welcome you today to our next hot topic discussion. For those of you who were able to join us last month, you know that this is a two-part webinar series entitled Lessons from the Intimate Partner Violence Field, Moving Beyond Surveillance and Screening Towards Safety and Wellbeing. And so don't worry if you weren't able to tune in to part one. The beauty of webinars is that they're recorded. And so we have that up on the SIREN website. It also went out in our newsletter. So if you didn't have a chance, I highly encourage you to check that out. And also just want to thank you for being here today for part two, where we're going to continue to learn from experts in the intimate partner violence field who have spent decades designing and redesigning strategies to promote violence prevention and healing. And so in part two of this series today, our presenters are going to be sharing their lessons learned about sustainable and equitable approaches to documentation, coding, and intervention. And these are relevant not only to intimate partner violence, but also to other social drivers of health. Next slide. This webinar would not have been possible without the generous support from Blue Shield of California Foundation. So we have much gratitude to our funders. Next slide. And I want to welcome back our two expert panelists. First, Dr. Elizabeth Miller is a distinguished professor of pediatrics and public health at the University of Pittsburgh School of Medicine, a physician in adolescent and young adult medicine, and medical director of community health at UPMC Children's Hospital, Pittsburgh. Trained in internal medicine, pediatrics, and medical anthropology, she has over 20 years of practice and community-partnered research experience in addressing interpersonal violence prevention among adolescents and young adults in community and clinical settings. And Lisa James. Lisa James is a vice president of health at Futures Without Violence. As part of the National Health Initiative on Domestic Violence, her over 20 years of experience at Futures Without Violence. In those years, she's collaborated with healthcare providers, domestic violence experts, health policymakers in over 25 states across the United States to develop statewide healthcare responses to domestic violence through training, policy reform, and public education. We're so excited to have both of you today. Next slide. And just before I hand over the virtual mic to both of you, I have been tasked with the responsibility of just some brief webinar logistics and news about upcoming events. First, this webinar is being recorded, and we will be sending a link to the recording to all registered participants when it's available. Second, we welcome your questions. It was so wonderful in part one of this series to see all of your questions in the Q&A. And so our panelists are gonna do their best to get to your questions, whether it's in the chat or during the Q&A portion of the webinar. So please bring your questions again and use that Q&A feature. We can't wait to hear from you. Next slide. And last, we just want to give a big shout out from the rooftops that registration is open for our SIREN 2025 National Research Meeting. That's occurring coming up soon in February, from February 2nd to 4th in San Diego. You can check out all the details and register on our SIREN website, and we hope to see you there. And now, without further delay, next slide, I would love to hand it over to our amazing panelists today. Thank you so much for being here.
Thank you, and thanks to all of you for joining. Real quickly, for those of you who weren't able to join with part one, I just wanted to lift up that I'm here representing Futures Without Violence. We're a national health and social justice organization working to end violence and create healthy families and communities here in the U.S. and around the world. And those are our offices in the Presidio, but we also have offices in Boston and Washington, D.C. Next slide, please. We have for a very long time, almost 30 years, have been home to the National Health Resource Center on Domestic Violence, which has been supported by the Administration for Children and Families to create connections between healthcare providers and systems and community-based violence prevention programs, and also to promote policy change and research around the connections between health and violence. Next slide, please. We also more recently, in the last 5 years, have been funded and designated by the Health Resources and Services Administration to lead health partners on intimate partner violence and exploitation, which is a National Technical Assistance Center specifically for community health centers to address intimate partner violence and exploitation. And I share that because you'll see throughout our talk today that there's a number of resources that we'll lift up. And I just want to let you know that those resources are available to you free of charge because of the roles that we play in these two technical assistance projects nationally. Next slide, please. And the reason that we do this work, and the reason that we have support from both our federal partners as well as from the Blue Shield of California Foundation, with whom we also partner with on many initiatives here in California, just again to kind of ground us, is because intimate partner violence is highly prevalent, more prevalent for women than breast cancer and diabetes combined. And it has significant and long-lasting health impact. The good news is that studies show that health professionals can make a big difference in preventing violence and supporting survivor health. So that's why we're really committed to doing this work together with folks like you. Next slide. I think particularly with the SIREN audience, wanted to make the connection between intimate partner violence and other social drivers of health. And you can see here on the slide how experiencing intimate partner violence really impacts an individual's economic status, education access, healthcare access. In each of those areas, we see abusive partners interrupting either schooling or access to care, and interrupting a person's work life and employment, and also really limiting that societal and community connection that we know is so important for a whole host of reasons. And so intimate partner violence in each one of these categories can really impact some of the work that we're all collectively trying to do to address social drivers of health. Next slide, please. But on the flip side, when you have healthy and secure relationships and families and communities, we are much more likely to see success in each of those areas as well. And so while we'll be talking about intimate partner violence and sexual violence intervention strategies and policy considerations, we really recognize that this is work that we're doing together with your work. And so we'll be complementing each other's interventions when we do this work together. Next slide, please. For part 2 of this session, we wanted to lift up, we had gone through some best practices in terms of interventions in part 1. But we wanted to lift up some of the challenges that we continue to face and that we've been grappling with some, and have some policy and practice recommendations around. And that is, even though intimate partner violence is one of the few social drivers of health that actually has a U.S. Preventive Services Task Force recommendation of to offer screening and brief intervention around intimate partner violence, we know that there's a recent Office on the Inspector General report that came out that only 43% of providers are following those recommendations. And we've seen other research that supports this, as well as just the day-to-day practice. And we know from that research, or that study, as well as from other analyses, that providers report these barriers that you see on the screen, time constraints, and we see that across every issue, as well as inadequate training. And that's why we really wanted to lift up a time-effective intervention, and that we have training resources available in our previous session. But also providers lifted up concerns about privacy and reporting requirements as a true kind of barrier, and gives them hesitation for even doing this work at all, because they don't want to put somebody at an increased risk. And they indicate that electronic health records, if there were more prompts and tools embedded into the electronic health records, they might be more comfortable implementing some of these comprehensive programs. So you see a link to that report on this slide, but we'll go ahead and lift up some of the recommendations in each one of these areas in the course of the next hour. Next slide, please. But before we do, I'll just lift up, as I said, Dr. Miller's going to recap for those of you who weren't here last time, what that sort of time-effective evidence-based intervention is, that on which we build our other recommendations around documentation, coding, and privacy.
Indeed. So thank you, Lisa. And thank you to the SIREN team for having us again. So delighted. And as noted, right, for those of you who were able to join us for part one, but for those who weren't as well, what we covered there was a little bit more about the clinic level and specifically provider intervention to be able to support survivors of intimate partner violence. And one of the things that we highlighted previously was that there are many, many reasons that our patients who are experiencing violence or have a history of intimate partner violence may not want to disclose during a clinical encounter about those experiences. And among the concerns are how that information may be documented, and we'll talk more about privacy and confidentiality. The intervention that we described in part one has a really nice mnemonic, the Q's intervention, C for confidentiality, meaning even if all we are doing is offering information, it should always be done privately, as well as after we have disclosed the limits of confidentiality with our patients. U for universal education. The idea here is that we offer resources and information in all of our clinical visits so that that is not dependent on patients having to disclose. And this approach, in part one, we talked about not only for intimate partner violence, but for other social drivers of health as well. The E for empowerment was to emphasize that we can share this information, saying it may be relevant for you, and suspect that this would be relevant for somebody that you know, friends or family. So we would love for you to take this information with you. And then S for support, which we touched on last time as well, about the importance at the clinic level to develop partnership agreements with local victim service agencies, but also other community organizations that are able to support our patients with the multiple social drivers of health that Lisa just reviewed. And so a key piece here is that doing this kind of universal education in a clinical visit takes me as a clinician less than 10 seconds to do. So is certainly time saving, is very survivor centered in the sense that survivors say, please give us information. Don't force me to disclose. So it's very survivor centered. But where we're going to shift the conversation today is what are the structural interventions that need to be in place so that providers can confidently do this kind of evidence-based intervention routinely, consistently. And so, Lisa, back to you.
Thank you. You see here on the slides that there are links to online trainings on how to implement Qs, as well as other provider and patient-facing tools. So just know those are available to you. Next slide, please. And when we think about that kind of intervention, and as we talked about in part one, it's something that can be implemented. It's an approach that can be used for other social drivers that you're addressing. And it can also be combined with screening tools if you are in fact using a tool like a prepare tool as well. So contemplate that combination and or offering universal education on its own. But as Dr. Miller talked about, over the course of the years that we've done this work, we can only train so much without having the interventions and the system support really there to back up the individual providers. So even when you have the most passionate champion, they need those systems level supports backing up them at a clinical level, and also to facilitate effective research and policy change. So wanted to lift up that there are a number of organizational readiness tools that we have developed, everything from quality improvement tools that you can really measure your practice and measure the impact that it's having on your patients or clients, as well as tools to prepare your practice. And so that we have recommended and sample protocols on all the steps that you might want to put into place before you start to address intimate partner violence. And we also learned that there's such an important need to create a space in the clinical setting or frankly in the community-based programs as well that really indicates that it's a safe place to have conversations. And so we have a number of resources, posters and what have you that can really help with those environmental shifts that will make it easier to have these conversations. And Dr. Miller lifted up that I know last time we talked about offering warm referrals to community-based domestic violence programs when somebody does disclose that they need help. We have both a national hotline that can address and support folks even in the most rural or frontier areas, as well as a very robust network of community-based programs all over the country that can receive referrals from healthcare providers. So it's important to create those meaningful partnerships, and we have some tools and resources around what that looks like available to you. So, but in addition to that, we were going to dive in a little deeper around safe documentation that is both for the clinical practice and also what might impact your research and referral processes as well. And also talk a little bit about sustainability strategies and some of the lessons we're learning from other states and here in California around leveraging Medicaid for violence prevention. Next slide, please. So first around documentation and coding, next slide. I lifted up that in that Office of the Inspector General report, providers are reluctant to even begin to have a conversation. I have also heard many times over the course of the years that I've been doing this work that providers are very nervous about documenting findings around intimate partner violence. Because they are concerned about the risk it might put the survivor in if that information gets out. At the same time, we are all hungry for the data and the understanding of the impact of this incredible impact actually on health. And so it's because of that that we've got this kind of competing demand, and we see that even in the UDS measures for the community health centers, we've got some new codes and new requirements to report intimate partner violence and human trafficking. And we have recommendations from many, many health associations to document and code and codes in place, particularly ICD-10 codes in place around intimate partner violence. So we need to come up with a way to be able to use these codes, document and be able to measure the impact and do our research in a way that is respectful and safe for survivors. Next slide, please. I mentioned some of the ICD-10 codes. I wanted to also lift up that there are a number of ICD-10 codes, but recently we have partnered with the Gravity Project, which I know you all are familiar with, to expand the set of both assessment tool codes to really get those into the codes into place, as well as an expanded set of diagnostic codes. And what I'm most excited about is the expanded set of IPV goals that are new and now available in terms of documenting not only what happened in terms of an assessment, but also what happened with diagnoses and what was actually provided to the survivor that can start to lift up what we're understanding about the impact of our intervention. And it reflects on a lot of other social interventions, as I talked about earlier. So is the survivor able to access safe housing? Do they report increased safety? Have they completed a restorative justice program? These are just examples of some of the goals that are now, codes are now available. What is their sense of financial security, again, because of that economic abuse that I talked about in the beginning of the session? Do they report a decrease in psychological abuse and social monitoring? So those are just some examples of the goal codes, and definitely check out those codes. And I'm thrilled to say that CUES, the Universal Education and support model that Dr. Miller described, is also being built as an intervention in SNOMED currently. So you'll have that at the ready as well. Next slide, please. But we want to be aware of the impact that the documentation might have on the survivor. And we want to be thinking about how to do that in a way that's as safe as possible. We have a number of different recommendations and principles that are available to you around what are the key elements of IPV documentation and what's really not necessary to include. And then also different strategies for how you can consider the safety of the patient when you're putting that information in the record. And we have a number of recommended tools and approaches around respecting the patient's autonomy and concerns and offering informed consent about what gets included and what you document, and really having a collaborative participation around that documentation process. In some states, you might have a reporting requirement for some injuries related to intimate partner violence. And we could spend a whole hour talking about those strategies, but I'll just lift up that when you do have to report, we recommend again that you follow a trauma-informed approach to reporting and really integrate and involve the patient when you're having to make that report. Next slide, please. So Liz, I'll turn it back to you to reflect on moving forward on both the privacy principles and also anything else you might want to add from your clinical practice around documentation recommendations.
Indeed. Thank you, Lisa. So next slide, right, we're going to go deeper into the weeds around the privacy concerns because they are so important. And right, we're going to conclude with saying we have tools and strategies to do this and to do this well. So really looking forward to your feedback as we go through this. As I was alluding to in the discussion of CUES, there are many, many reasons that our patients are hesitant to share with us that they are struggling in the context of intimate partner violence, but also about sharing their struggles related to economic insecurity, housing instability, and so forth, for fear of shame, judgment, what we're going to do with that information, who's going to get a hold of this. And so none of these kinds of questions should surprise us, right? The kinds of scenarios that are concerned for survivors, like what's going to happen if my partner finds out I even had this conversation with my provider? What would happen to my partner who works, right, for the health center? What will happen if and can they access my health record? What will my provider think of me if they see that I have disclosed violence? And so concerns about partner retaliation, but also the fear of judgment and impact on the care that a person might receive if they disclose. So next slide. This goes in even more deeply around health data. And, you know, of course, so myself included, right? When I'm in the exam room, I'm there trying to pay attention to my patient, but I'm also typing into the electronic health record. And there are many, many questions, right, that our patients have about how our health information, how their health information is going to be used. Like what gets written in electronic tools about experiences of violence and sensitive health information, who has access to the information when it's submitted to the platform, including any personally identifiable health data. And what control do I have over that health information? What are my rights as a patient, as a survivor, and many, many other questions. I take care of adolescents and young adults, so you add this other layer of concerns about breaches of confidentiality that young people have as well, and who is going to see this information. So next slide. So, some key principles, right, that are core to our work in the healthcare field are recognizing that individuals should have the right to access, correct, amend, and supplement their own health information, should receive notice of how their health information is used and disclosed, including specific notification of the limits of confidentiality, and that providers must offer and respect patients' choice of communication preferences, and that we build this into the electronic health record as a mandatory field, and that we have privacy safeguards and consents that actually follow, right, that health information, and that we as providers need to have broad discretion to withhold information when disclosure could harm the patient. And there should be strong and enforceable penalties for violations of that privacy. I was thinking about this earlier this morning as I also take care of young people who are incarcerated, and we've added additional layers of kind of break the glass and additional security around all of our charting for this group of young people, so that we can really safeguard their health information. Next slide. So with those privacy sort of principles in mind, right, specifically for survivors of intimate partner violence, the new federal rules around sharing health data went into effect in 2021, and really core to the Cures Act was supporting information exchange, right, with this idea that this would support care coordination and holistic care, and try to limit information blocking. And the idea, of course, was that patients would benefit from seamless access to health data by the care team. And even as the Cures Act was coming into being, a lot for us in the violence prevention field about how survivors' health data would be shared. So next slide. So within the Cures Act, right, the requirement to share data if requested, the request for health data on behalf of the patient certainly should be acted on, and the information requested be shared. The rule, though, creates this presumption that data should be shared when requested. Does not mean, right, that those data must be disclosed to all requesters for any purpose, right? There are a number of really important exceptions to this rule. And there's no requirement for proactively sharing or publishing health data unless requested, nor is there a requirement to proactively make those data available or to put it in the portal, right? And so we need to be, certainly as we're moving forward to provide the best quality of care for survivors of intimate partner violence, be very, very clear with our chief health information officers that they understand why and how we will be sharing data and sharing health data specifically. So next slide. There were, when HHS put this all in place, very clear categories of exceptions. And I will say that in my day-to-day clinical work, because I take care of adolescents and because I take care of young people who have experienced relationship abuse and sexual exploitation, I use this exception every day in my clinical practice. These exceptions are around preventing harm. So it's reasonably necessary practices to prevent harm to a patient or another person. And this could be sort of the consequences of disclosing the exposure to violence that could be found out by an abusive partner or others. And the privacy, of course, refusing to fulfill a request to protect a person's privacy. So next slide. To go specifically into that exception about preventing harm, the provider really must believe that the denial will substantially reduce the risk of harm. And I hope that we're making the case that for supporting survivors of intimate partner violence, that we use this exception. And for record-keeping purposes, the process by which providers can apply this exemption should be in writing at the health center and applied in a consistent and non-discriminatory manner. The challenge for us right now in implementing this in practice is it requires providers, myself included, to click on the button that says, do not disclose this, do not publish this to the portal, and then to click on the button that explains this because I'm concerned about the risk for harm. And we will talk in a little bit more about the possibility of policy for actually having you have to unclick in order to share as opposed to clicking to prevent the sharing. And so we'll talk about that more in a moment. The next slide is about the exception for privacy, so that as providers, we can withhold data if an individual requests information not to be shared, or if the provider was unable to obtain consent. And again, that every practice needs to have clear and transparent policies for how we're going to apply these privacy exceptions to protect survivor confidentiality and autonomy. What I'm trying to say here is we should not be leaving this up to individual providers, right? That we need to have system-wide clinic level policies and to be able to actually hold ourselves answerable to each other, but most importantly to our patients. Then next slide. So there are, in a short webinar like this, not enough time to go into all of the best practices, but these slides will be shared with you, include best practices for providers around the importance of having these documented policies for applying exceptions and really helping and making sure that clinical teams understand that we do not share sensitive data unless requested, and many of the key resources. So Lisa, I'm turning it back to you.
Thanks, Dr. Miller. I think what I want to leave this section of the conversation with is just, I think you can hear that what we're really trying to grapple with in the field is the understanding that we know that documentation can promote care coordination, and also we know and are passionate about research as it relates to intimate partner violence and health consequences and the importance of interventions. And of course, none of us want to do that in a way that is putting somebody at risk. And we have heard loud and clear from providers that they're concerned about that, and it has stopped them from responding altogether. So all of what you're hearing here is our effort to recognize that we've got some real systems challenges, and we've made some pretty significant advances. And we've got a little bit farther to go in terms of trying to make those individual advances and policy changes default and not rely on an individual provider, and really create them at the systems level. So we have the solutions, but we need to make them easier, I would say, for people to implement. Next slide, please. Part of that work is around looking at the electronic health tools that are available to us, and how can we really work within those systems and tools to make this easier. And you heard again from that OIG report that providers have specifically said, if I had some best practices or some scripts embedded into some of our tools, that would help me facilitate in the busy day-to-day. So next slide, please. We have been over the years doing a number of different projects and leading a number of different projects that look at and evaluate how helpful are embedding provider scripts into electronic tools. And actually, this is something that Dr. Miller worked on, where she found that provider scripts were particularly helpful in facilitating conversations with patients about healthy relationships and could be incorporated into the electronic health record in the context, in this case, around implementing universal education and addressing reproductive coercion. Next slide, please. We have known that those scripts are so important for training, and so it makes sense that we want to embed them into electronic health records and other electronic tools. And so at Futures Without Violence, we partnered with Ocean Epic to create some new tools, and they have a module around cues and intimate partner violence that folks who use Ocean Epic can access. Next slide, please. I'll just lift up that there's a whole toolkit that Ocean has put together with Futures Without Violence around each of the steps of the intervention and giving background information about what is cues and how does it work and all the steps of the intervention. So these are available again to Ocean Epic tool users. Next slide. And I am pleased that it incorporates all of those steps in a way that can be implemented quite briefly around disclosing limits of confidentiality and seeing patients alone, offering and embedding some scripts around how to start conversations, because it's not easy to start a conversation about intimate partner violence if you're not used to doing it. And then also some clinical decision supports really embedded and visit specific. Because how you might want to address somebody's health in the context of an abusive relationship would look a little different if you're in an adolescent medicine or if you're in reproductive health or primary care. So I just wanted to share that those are available. Next slide. And a number of other flow sheets are also available, really thinking through how can this be put into place in person and also for virtual visits, because we really began this work with them during the pandemic. Next slide, please. We also, before I switch over to community referral platforms, I'll say we're also working with eClinicalWorks to embed tools and resources in the same way. We are we are actually complete in that process, but what we're trying to do is exactly what Dr. Miller lifted up, which is have it be a default so that any documentation does not automatically go into the open notes. But rather somebody has to request it. But that's been, as you might imagine, just a lot of back and forth with their legal team about what's required. And I think at the core of it, we want to be able to acknowledge that for some survivors, it's really critical for them to have the documentation in their record. They might want that for a custody case, but for others, they might not. And so it's all about those conversations and making sure that you can have that conversation and in a meaningful way while also pushing towards systems change. So now I'm going to shift gears a little bit, because another part and another step of this work is connecting up with community referral platforms. And next slide, please. Similar to documentation of any kind, as people have moved towards using community referral platforms more and more, it's a real opportunity to streamline and connect survivors up with critical services. And there are some particular safety and privacy considerations that are I think unique to intimate partner violence, but also relevant to other social interventions as well. So as we have seen more folks use some of these networks, we see the opportunity, but we also have some tools and resources to think about how you can still facilitate these warm referrals, but also keep people as safe as possible. Next slide, please. I think I pretty much lifted this up, but we do know that survivors can benefit from that coordinated care. And it's really important to be able to share real-time availability of services and find out whether or not they got the help they needed. We don't want to be doing all this work and not know whether or not they actually got the help they needed. At the same time, next slide, we want to be thinking about doing that in a way that actually is safe. So we've seen some community referral platforms really connect patients up to national hotlines and local community-based programs. We see also that survivors and their care team really have benefited from knowing what those services are. Next slide. But we also know that some of the ways in which they're created, the information is so embedded and available to all others in the community referral network that it has the potential to put somebody at risk. So if you document that Dr. Miller was accessing domestic violence services, but also the Child Protective Services is in the community referral network, or law enforcement is in the community referral network, who has access to the information about what resources are being accessed, and how can you keep that as private and confidential as possible, particularly in the case of intimate partner violence, so that there isn't an unintended consequence of either some kind of systems involvement that was unwanted, or other information getting out there to the abusive partner about what has been referred. So just know that there are questions that survivors have in the same way about other documentation about who sees the data and how is it used. And we have been developing recommendations about strong consent forms and recommendations on how to work with these referral platforms to really try to segment the data in a way that is safe as possible, and put some quality controls around who's entering into it and who can see the data. Next slide, please. I hope you're still with us. I know these are kind of complex and wonky slides, but it is something that we're seeing in the day-to-day practice, and also as we move towards enhanced care coordination and research. And it's so important for us to not be left behind, but we also have to think through these privacy considerations. And they really reflect the same that we have around documentation, just being very careful about informed consent, being very supportive of survivors' agency around requesting restrictions, and just thinking through some of those safeguards that are really critical in the referral platforms. Next slide. So just know that there is a whole memo that we have here available that talks through this in a little bit more detail. Please feel free to reach out as well if you want to discuss it further, and we'd be happy to do so. Next slide. This data referral and social referral platforms came up very significantly at the national level for us at Futures Without Violence, as we started to get a lot of requests about how can we partner with some of those platforms as more and more states started to think about leveraging Medicaid for intimate partner violence prevention. And as they started to do that, they were leaning on some of these referral platforms, and that's where we recognized that there was both an opportunity but also a challenge that we needed to address around privacy. So I'll end our section around lifting up some models around Medicaid, and it gets to that other kind of barrier for providers in doing this work, and that is really how, lack of time is one thing, concerns about privacy, also how can I keep this sustainable and be reimbursed for the services that I provided. And so with the shift that you all are so familiar with, around leveraging Medicaid for social interventions, including intimate partner violence. We've seen some models that are quite promising and that are grappling with some of these challenges. Next slide. The first, well, I just mentioned that we have increased interest and more as CMS and others start to incorporate leveraging Medicaid for social interventions, intimate partner violence is getting included. Next slide. And North Carolina's Healthy Opportunities pilot was probably the first to do it most robustly, and it is through their referral tool NC Cares 360 that we really processed a lot of those challenges and have some great lessons learned for making recommendations for other closed loop referrals and systems. So that you can, in fact, make a referral tool and community-based organizations, including domestic violence programs, are actually being reimbursed for their violence prevention services by Medicaid through the Healthy Opportunities pilot. So next slide. It took quite a while to work through those privacy considerations and really realize the potential for survivors. But now we have a great model, not only for what is a billable service, but also how can you protect the privacy and confidentiality to the best of your ability in doing this work. So they're carefully monitoring the program, but it has been rolled out and so far so good. As it expands. And of course, with all things Medicaid, we will see what happens in the upcoming year with the new administration. With any administration, there are changes to policy. So we'll see what happens around Medicaid specifically. But for now, the North Carolina program is continuing. Similarly, in Delaware, next slide, please. They also are leveraging Medicaid to support community health workers that are domestic violence specific, and they're now able to offer bilingual, duly trained advocates and DV advocates to provide care coordination, support healthcare providers in the work that they do, informed counseling and support and education. And they're seeing some real positive impacts on the health of their clients. Next slide, please. They are using a braided funding model, so it's both supported by grants and community benefits and also state funding, but also the managed care programs are a key part of it. But again, they've managed to figure out a way, next slide, to address those confidentiality concerns and work with their Medicaid department as well as their creators of their social referral platforms to think through all of the benefits of confidentiality and really have clarity around what can be shared in order to facilitate supports and outreach to survivors that weren't being reached before they implemented this program. Next slide. Okay, that was it. That was a lot. I'll just say there are a number of tools and resources attached to the end of this this slide presentation. I won't go through them because I would love to have time for comments and questions, but just know there are tools around the Epic Smart Epic tool that I talked about, our privacy principles, model protocols, and other tools to create sustainable relationships with community-based programs. But I'll stop there, and I think we can take the slides down if you like, or and help me out with what I've missed in the chat.
Thank you so much to both of you for that fantastic presentation. And we had a couple questions come in through the Q&A that feel free to expand upon the answers already provided. But while you're having a chance to look at those, we also had a few questions come in through the chat. And so one question comes from one of our attendees who's asking about, noting that the cues can be really simple to do in practice, but not having a quick way to describe those charting options and all the important stuff that you talked about today around privacy, safety, and confidentiality. And so wondering, especially in a safety net setting where a lot of the patients are not necessarily understanding all, in not just safety net settings, anywhere, not necessarily understanding all of the EHR options. Do you have any examples of what you would say to patients about documentations, about the patient portal?
I can certainly start with that and say first a hello to our dear friend, Dr. Lee Kimberg, who posted the question. So thank you for this. And to say, I'm going to answer in two ways. One is that for basic documentation of social history, when doing the cues approach, we actually, for our templated like goes into the portal, you're in for your well visit and so forth. Our social history actually has a phrase that is confidential, conversation about relationships and resources, we're offered, we have a nicer way of saying it, but it's essentially this like phrase that says, we talked about this kind of range of healthy relationships and resources were offered. And that is kind of the goes into and is sufficient for billing in terms of the social history. And then the training, and certainly as an adolescent young adult clinician, where these layers of supporting both survivors, but survivors who are also minors, right? We are really attuned to putting a lot more detail in sensitive notes and then blocking those from the portal. So again, really remembering both sensitive notes, right? But that doesn't necessarily block that from the portal. And so being absolutely sure that we have, that we click on both. And so that is one of the ways to do this more, just as kind of our routine clinical practice. Then when we have disclosures, it is so important as part of just allying and supporting and validating our survivors' stories is say that this is so impactful for your health that there are parts of your story that we really need to document thinking about your overall health. And again, putting that in a sensitive note blocked from the portal. But again, we need to be always including our patients in that conversation about how should we document. And for our patients for whom English is not their primary language, right, working with our interpreters so that they understand what we are getting at in terms of sensitivity and privacy and confidentiality is so critically important. This is truly ongoing, it's ongoing training for our clinical teams as well. And then Dr. Kimberg had an additional question posted in the chat about what about pediatrics, right? And I will say very, very pleased that the American Academy of Pediatrics revised their guidelines around intimate partner violence. And in a second, I will pull those up and put those in the chat as well. But the key thing for pediatrics is to say, super important to remember that intimate partner violence can absolutely impact our parents and caregivers, and that putting anything in the child's record, right, could be visible to another parent, caregiver, even if they're not the custodial parent. And so it very, very critical that we are both always thinking about supporting survivors in pediatric practice, but being simultaneously mindful about where in a child's health record anything about the parent's exposure to intimate partner violence is recorded.
Thank you, Dr. Miller. I wanted to do my best with Brina's question that I see in the chat around those who are implementing the AHC tool in inpatient settings and complying with the CMS requirements around social needs screening. And what codes should be used. I did want to lift up those newer gravity codes that we worked with the Gravity Project. And I wanted to say, I think for those of you who are implementing those tools, the Accountable Health Communities intake tools, that especially when the cues intervention gets built into SNOMED, I think there might be an opportunity to lift that up. And it's a great combination of offering universal education and then bridging to a screening tool. And we've got some scripts that can help with that, but it's not really rocket science. It's basically just offering universal education so that no matter what, if the person chooses not to disclose, they get the resources. And then saying we also find that reflecting on some of these questions has been helpful to people in understanding what's going on with their health. And then introducing the Accountable Health Communities tool. So that's the practice piece. And then the codes, eventually we'll be able to lift up the cues code, but also there are assessment codes, diagnoses codes, and as I mentioned earlier, those goal codes that I'm so excited about, so that we can kind of finally get to the response and the result, and not only our understanding of the problem. I hope that got to your question. Please feel free to pipe in if it did not.
Fantastic. And then I just want to ask both of you a big picture question. So you gave us so much important information today, and I'm wondering where you think the biggest evidence gaps are. So to really move the needle on improving our care delivery and improving lives at the end of the day, where do you see the biggest evidence gaps? Where does research really need to step in and create some more evidence?
Okay, Dr. Miller, my researcher friend, you get to go first.
So I think one of the biggest areas actually is studying kind of the social and structural interventions, right, around mitigating both the impacts of intimate partner violence, but also intimate partner violence prevention, right? So, for example, to what extent do housing first policies, right, help or hinder, right, the care for survivors of intimate partner violence? So, when I'm talking about structural interventions, it's that list, that beautiful diagram that Lisa showed of how intimate partner violence can is so linked with other aspects of our sort of economic and social kind of ecosystem, and so that is certainly where I think big research gaps are. I do think in terms of health services delivery, I am not firmly convinced that social determinants of health, SDOH screening, and really that is a way for us to actually move the needle on health outcomes, right? And so I do think that there needs to be a fair amount of curiosity among those of us who do clinical research around, is screening the answer, or are we in fact going to find what we have known about intimate partner violence screening for many years now, which is screening alone does not actually improve the quality of life for survivors. It's really about implementing meaningful interventions, and those meaningful interventions have to be in partnership with not only victim service agencies, but many other community partners as well. And we do need to figure out how to better support, including fund, those community partners who help us take care of our patients. Lisa, what else would you add?
I think that's perfect. And I think it's just about understanding the way in which the screening tools have leveraged important conversations that open the door and how do we get at those conversations, and how do we offer those resources regardless, and not only getting sort of stuck in our intake and thinking about what is actually needed. So I think I'm just saying the same thing as you, Dr. Miller, and for sure around the prevention and the systems level, primary prevention, that's a big gap with research.
Fantastic. I want to thank you both for being here with us today, and not only today, but for both parts of this two-part webinar series, and to all of you who are able to join us today or listening to the future recording of this webinar. Thank you all.
Thank you so much.
Thank you.